This is an introduction about the sellar and the parasellar tumors. The sellar region encompasses the sella turcica with adjacent structures including the CSF spaces, the hypothalamus with the bottom of the third ventricle, and the cavernous sinus. As regards sellar lesions in adults, the most common lesion is pituitary adenoma, while the second most common lesion is sellar meningioma. As regards sellar lesions in children, the most common is craniopharyngioma, while the second most common is hypothalamic glioma. As regards the imaging modalities of the sellar region, we'll start by the CT scan. The bone of the skull base is very thick, so it can induce a beam hardening artifacts around the sella. Also, we know that the CT scan is poor in soft tissue characterization. Because of these reasons, the CT scan is not preferred in radiological assessment of the sellar tumors, but it is usually used in the preoperative planning when the transsphenoidal approach is chosen. MRI is the gold standard for investigation of pituitary lesion or sellar lesion. This is because it is superior in soft tissue characterization. It can clearly show us the soft tissues around the sella like the optic chiasm, cavernous sinus, temporal lobes, and carotid artery. Usually we use the sagittal and coronal planes for the best assessment. The thickness of the slice is usually 3 mm or less because the sellar region is very narrow. But why the contrast injection is very important in sellar lesion assessment? The pituitary gland is involved in the control of the levels of hormones in circulation, so that it is considered as one of the circumventricular organs. To do that, it must lack the blood-brain barrier. So after injection of contrast, the normal pituitary gland enhances faster than the tumor. But 10% of pituitary adenomas can take the contrast with a velocity very close to the normal pituitary, and this makes them undetectable by the standard MRI. Although the clinical picture of the patient is highly suggestive, and this can confuse you. As you see in this example, the tumor took the contrast rapidly as the gland and disappeared within it. To solve this problem, we need a fast imaging technique that can detect the contrast wash in and wash out, and thus it can detect these lesions that cannot be detected by the standard methods. In this example, you see the tumor is detected at 30 seconds after injection of contrast, while after 60 seconds, it disappeared. This imaging modality is called dynamic T1 weighted fast spin echo. It is not supposed to be routinely used. It is preserved for those problematic cases only. But imagine that this high sensitivity of MRI has a disadvantage. How? It created the problem of high detectability of incidental lesions in persons who have no symptoms and with normal lab results. Many of these lesions are non-functioning pituitary microadenomas. Some microadenomas that secrete adrenocorticotropic hormone are too small to be detected even by dynamic study, although they can secrete large amounts of ACTH to the extent that leads to Cushing disease. And the problem here is the site of the pathogen. Is it located in the pituitary gland or elsewhere in the body? In these cases, we may need a direct sampling of the blood from the venous drainage of the pituitary to measure the levels of ACTH in it. The high levels will confirm that the source is within the pituitary. This vein is the inferior petrosal sinus. This procedure is done bilaterally to define the site of the lesion, either on the right or on the left side of the gland. In the next video, we will start speaking about pituitary adenoma.